No more crooked teeth. A parent's guide to avoid the orthodontist. Everything you need to know about facial growth and early intervention interceptive treatment. Written by Ryan Van Rensburg.
Disclaimer. The content of this book is not medical advice or a treatment plan and is intended for general education and improved public awareness. Many of the biological processes have been simplified and sometimes exaggerated in order to improve understanding. The content briefly describes why there is an increasing occurrence of malocclusion in modern society and the current state of treatment modalities offered by dentists and orthodontists. This content should not be used to self-diagnose or self-treat any health, medical or physical condition. The content should not be used instead of consulting a medical professional or to replace the medical advice they give you. Consult with your healthcare provider before doing anything contained in this content.
Preface. Have you ever wondered why some people have crooked teeth while others have perfectly aligned pearly whites? The traditional thinking was that crooked teeth, also known as malocclusion, was all to do with genetics. The scientific evidence now suggests that crooked teeth are caused by a poorly formed maxilla and mandible which have not grown sufficiently to accommodate all of the teeth. This book will describe the mistakes that can lead to poor facial growth, now being termed facial dystrophy or dental space deficiency syndrome, from birth to adolescence, and the lifelong consequences faced by people with this condition. This book is specifically aimed at parents of young children, nursery school teachers, and prenatal educators. Contents. Introduction. Chapter 1, Everything You Do Matters. Chapter 2, Life with Crooked Teeth and Poor Facial Development. Chapter 3, Muscles of Mastication. Chapter 4, Bones of the Jaws. Chapter 5, The Tongue. Chapter 6, Breast is Best. Chapter 7, Infant-Led Weaning. Chapter 8, Primary to Permanent Teeth. Chapter 9, Mouth Breathing and All of the Devastating Lifelong Consequences. Chapter 10, The Wrong Diet. Chapter 11, Parafunctional Habits. Chapter 12, How Teeth Move Through Bone. Chapter 13, The Problem with Traditional Fixed Orthodontics. Chapter 14, TMD on the Rise. Chapter 15, Is your smoking ruining your child's face? Chapter 16, Myofunctional Therapy. Chapter 17, Summary of the Beneficial Forces. Chapter 18, When to Intervene. Chapter 19, Early Intervention. Chapter 20, A Timeline of Events. Discussion. Introduction. There are two schools of thought with regards to the reason why there is an increasing occurrence of crooked teeth in our modernized Western society. The traditional and antiquated view was that the problem occurs purely because of genetic factors, a mismatch of genetics, or just pure heredity from one or both parents. A new scientific understanding asserts that teeth are not able to fit into the mouth due to lack of space caused by poor maxillary and mandibular development. Proper maxillary and mandibular development is facilitated by good posture of the tongue, lips, and neck, and the proper use of the muscles of mastication. Due to the modern diet, lifestyle, and behavior that deviates far from that of our ancestors, there has definitely been a gradual decrease in the size of the jaws for many generations. Scientists say that the trend is towards smaller jaws and bigger brains. At this stage of human evolution, it would therefore be more realistic to say that crooked teeth are caused by both genetic determinants as well as environmental and behavioral factors. With an effective preventative strategy, we can expect to have straight, well-aligned teeth, but can also expect, in some cases, to have insufficient space for the third molars, wisdom teeth. For many people, however, the inherited functional decline is so advanced that no wisdom teeth will appear at all. Within the field of medicine, there are two ways to address an ongoing epidemic: prevention or treatment. The treatment for crooked teeth is a very well-established multi-billion-dollar global market. This treatment mostly comes in the form of fixed orthodontics, braces. Fixed orthodontics are extremely effective at moving teeth through bone, and with some expertise a perfectly aligned smile can easily be achieved. There are unfortunately some major limitations and, in some cases, dire consequences with regards to conserving teeth and developing the facial bones. Fortunately, there is a way to prevent malocclusion and completely avoid the need for traditional orthodontic treatment. This involves a process of naturally developing the facial structures, starting from birth, so that all of the teeth can fit in the mouth. For children who need a little help along the way, there are early intervention interceptive techniques and appliances that can assist with facial development. Chapter 1. Everything you do matters. Why the sudden acceleration in functional decline? The process of evolution and genetic mutation is slow and gradual, and it is constantly happening to us. Our genes adapt to the environment and the physical demands of our existence. The changes occur for a gain of function or loss of function. Noticeable changes are only evident after numerous generations. Fortunately, we don't have to look at any anthropological studies or any theoretical models to see the evidence of hereditary functional decline. We can just simply observe the vast genetic variation that exists within our species right now. Population groups whose recent ancestors were less industrialized and more rural seem to suffer no malocclusion, facial dystrophy, or dental space deficiency syndrome, or any of the associated maladies. On the other hand, modernized Western populations have an extremely high incidence of all of these problems. We can conclude that malocclusion is a modern-day problem. The task is to identify where we have gone wrong as a species and what to do about it. Almost every mammal on Earth has teeth. In some sense, we are all born to chew, masticate. The dentition of any animal is always perfectly suited to its particular diet. In addition to facilitating the ingestion of nourishment, teeth aid in the exploration of the environment, enabling young animals to grasp, chew, and manipulate objects. The facial and dental morphology of our ancient ancestors developed in response to a particular physical workload. If this workload is removed or substantially reduced due to a change of environment, lifestyle, and food options, then there will be a predictable loss of functionality. Human intellect is inclined to produce efficiency and productivity. Industrialization has caused an improvement of overall health and life expectancy due to the availability of medicines, vaccines, antibiotics, and medical interventions. Industrialization also brought with it heavily processed, high-calorie, low-nutrient soft foods. There has been a dramatic reduction of physical activity required to obtain food, and there is almost no effort required to ingest this food. Muscle and bone are easily affected in a short amount of time by an increase or decrease in workload. Muscle use causes muscle and bone growth, whereas muscle inactivity causes atrophy of both muscle and bone. It is important to note that malocclusion is very seldom caused by the size and shape of the individual teeth. The teeth are not to blame and are almost always morphologically perfect. The arrangement of the teeth is, however, an indication of the size and shape of the underlying bone. Note also that the root of the tooth, which is embedded in the bone, is larger than the crown, the part which is visible. Our genes are permanently being affected by our environment. People in industrialized societies are having children later in life. The older the parents are before they conceive, the more time there is for genetic mutations to occur. Parenting has changed due to lifestyle factors and the many commitments and distractions of modern-day life. There is a hereditary snowball effect. Children born into a modern, industrialized society are likely to start life with compromised genes because their parents lived on a poor diet and adopted poor habits, and secondly, the children do not reach their full genetic potential because of their own poor habits and poor diet. Each subsequent generation is incrementally worse off than the previous. Every living creature surely deserves to reach their full genetic potential. Anything that stifles this process must be avoided at all costs. Modern humans have deviated too far from what is natural and are suffering the physical consequences. Chapter 2. Life with crooked teeth and poor facial development. There are many lifelong challenges for people with crooked teeth and poor facial development. The appearance of crooked teeth is the visible sign of a chronic underlying pathology. This pathology has numerous physiological and psychological consequences and financial impacts. Physiological. 1. Impaired function. Crooked teeth are a component of a poorly formed masticatory architecture. The masticatory system is composed of muscles, tongue, bone, joints, and teeth. If one or more components are compromised, the entire system is affected. 2. Poor maxillary development. The roof of the mouth is the base of the nasal passages. A poorly formed maxilla means a poorly formed and constricted airway. This can cause breathing difficulties, increased incidence of allergies, deviated septum, and nasal obstruction. 3. Increased risk of dental problems. Crooked teeth can contribute to various dental problems. Misalignment can cause uneven pressure distribution during biting and chewing, leading to excessive wear on certain teeth and increased vulnerability to chips, fractures, and enamel erosion. 4. Temporomandibular joint, TMJ, disorders. If the equilibrium between structures of the masticatory system is compromised by unnatural movements and unnatural resting positions, the jaw joint, which is the movable and most adaptable component of the system, is occasionally in a position of slight dislocation. This places unnatural strain on ligaments and muscles, causing constant and reoccurring pain. 5. Difficulty in proper oral hygiene. Crooked teeth can make it challenging to maintain good oral hygiene. Misaligned teeth create tight spaces and overlapping areas that are difficult to clean properly with a toothbrush or floss. This can lead to an increased risk of plaque buildup, tooth decay, and gum disease. 6. Speech difficulties. In some cases, crooked teeth can affect speech patterns. The improper alignment of teeth can interfere with the normal placement of the tongue and alter airflow during speech. This can result in speech impediments such as lisps or difficulties in pronouncing certain sounds. 7. Poor facial aesthetics. Good aesthetics is usually closely related to good function and health. A narrow maxilla and retruded mandible with crowded teeth are signs of a structural imbalance or underdevelopment and will be perceived as deficient. Individuals with a well-developed masticatory system will have strong facial features with high cheekbones and a well-defined jawline. 8. Symmetry. Crooked teeth can disrupt the symmetry of the face, which is generally considered attractive. Straight teeth tend to create a harmonious balance, while crooked teeth can create an uneven or unbalanced appearance. 9. Smile aesthetics. A smile is one of the first things people notice about others, and straight teeth contribute to a pleasing smile. Crooked teeth can detract from the overall appearance of the smile. Straight teeth are often considered a sign of a confident, attractive smile. Psychological. 1. Self-esteem. While the physical consequences of crooked teeth are significant, the psychological impact should not be overlooked. Many individuals with misaligned teeth may feel self-conscious or embarrassed about their smile, leading to a negative impact on their self-esteem and overall well-being. 2. Social challenges. Living with crooked teeth can present certain social challenges. Society tends to place great importance on physical beauty, and having crooked teeth may lead to self-consciousness and feelings of inadequacy. Individuals may face judgment, stereotypes, or even bullying based on their appearance. 3. Long-term emotional impact. The emotional impact of living with crooked teeth can be significant. Many individuals with dental imperfections may experience social anxiety and feelings of isolation, which may contribute to poor mental health. 4. Attitude. A person may develop a poor attitude towards their own teeth, resulting in less care and inadequate hygiene, and as a result may suffer from increased dental decay and cavities and the accompanying toothache. Financial impacts. 1. Individuals may attempt numerous orthodontic procedures, such as braces or aligners, to correct their teeth. These treatments can be time-consuming, painful, and extremely expensive. 2. People with crooked teeth and poor dental hygiene are more likely to need costly restorative dental treatments and dental appliances to treat TMJ disorders. 3. Persons with impacted and poorly erupted molars may have to have expensive surgery to have these teeth removed in theater. 4. People who feel self-conscious and have low self-esteem are usually less confident and may have a reduced earning potential in the workplace. Chapter 3. Muscles of mastication. The muscles of mastication are a group of muscles located in the head and neck region that are responsible for the movement of the mandible during chewing. These muscles are essential for the process of digestion and are among the strongest muscles in the human body. It is important to note that most of our muscles exist for one main reason: movement. They achieve this by expanding, relaxed state, and contracting, activated state. The muscles are strongly attached to the bones, and when the muscles contract, the bones are pulled by the muscles. Resistance exercise causes the muscles to grow and develop to meet the demand. The strenuous work done by the muscles places a pulling force on the bones. This pulling force exerted on the bones causes them in turn to strengthen and grow. The muscles of mastication consist of 4 pairs of muscles, namely the temporalis, masseter, medial pterygoid, and lateral pterygoid muscles. Each of these muscles has a specific function and works in coordination to produce the required movement of the jaw during mastication. The temporalis muscle is a broad, fan-shaped muscle located on the side of the skull above the ear. This muscle is responsible for elevating and retracting the mandible during chewing. It originates from the temporal bone and inserts onto the coronoid process of the mandible. The masseter muscle is a thick, strong muscle located on the side of the face. This muscle is responsible for elevating the mandible and is the primary muscle used for biting and grinding food. It originates from the zygomatic arch and inserts onto the angle and ramus of the mandible. The medial pterygoid muscle is a deep muscle located on the inside of the mandible. This muscle is responsible for elevating and protruding the mandible, and it works in conjunction with the masseter muscle to produce powerful contractions during mastication. It originates from the pterygoid process of the sphenoid bone and inserts onto the medial surface of the mandible. The lateral pterygoid muscle is a small, flat muscle located on the inside of the mandible. This muscle is responsible for protruding the mandible and helps to move it from side to side during chewing. It originates from the greater wing of the sphenoid bone and inserts onto the condylar process of the mandible. All four of these muscles work together to produce the coordinated movements required for efficient chewing and swallowing. The pterygoid muscles are small and located internally. Our main focus is to develop the masseter and temporalis, which lie just beneath the skin. We can easily see and feel the movement of these muscles during chewing. These muscles, like any other, will only grow in response to an increased physical demand. Poor development of these muscles has a major effect on the growth of the facial bones and the appearance of the face. The only way to develop these muscles to their maximum potential is by chewing tough foods. This needs to begin as early as possible. Babies are usually introduced to solid foods at about 6 months. At this age, infants will have an instinct to self-feed, and when food is placed in the mouth, an automatic chewing reflex is activated. The molars, chewing teeth, will only erupt some months later, but by that time the chewing action and eagerness to chew should already be well developed. Chapter 4. The tongue. The human tongue is a complex organ that plays a crucial role in our daily lives. It is not only responsible for tasting and swallowing food, but it also enables us to speak and communicate effectively. The tongue is intricate and also functions as part of the masticatory system and assists in facial development. It is composed of 8 muscles that work together to produce the various movements required for speech, chewing, and swallowing. The tongue is attached to the hyoid bone, which is located in the neck and acts as an anchor for the tongue muscles. The tongue is also connected to the oral cavity by a band of tissue called the frenulum. The upper surface of the tongue is covered in papillae, which contain taste buds that allow us to taste different flavors. The tongue plays an important role in maxillary development during infancy and childhood. Correct tongue posture and swallowing movements, swallow patterns, contribute significantly to the development of the facial bones. Tongue posture. When the tongue is in its correct rest position, postural position, resting against the roof of the mouth, it exerts a light force on the maxilla and upper teeth. This constant force promotes forward growth and expansion of the upper jaw, which can help create more space for the teeth. However, when the tongue posture is incorrect, such as when the tongue rests in the lower part of the mouth or protrudes between the teeth, it can create inward forces on the maxilla, leading to a narrow upper jaw with less space for the teeth. Ideally, the tongue should always return to the correct rest position automatically without any conscious thought, even when asleep. Tongue tonicity refers to the level of muscle tension or strength in the tongue. Correct posture of the tongue ensures good tongue tonicity. The tongue muscles are in a constant state of partial contraction. A person with good tongue tonicity is much less likely to be a snorer or suffer with sleep apnea. It is important to note that almost all mammals with tongues do not create an empty cavity when the mouth is closed. The space is almost entirely filled by the tongue. The palate of a chimpanzee, for example, is flat and the tongue has nowhere else to go but against the palate. It is no coincidence that the tongue of every animal is perfectly shaped to fit its palate. Swallow patterns. Special attention must be paid to tongue position during swallowing. Swallowing is something we do all the time, not just when we eat. During a correct infant and adult swallow, the tongue pulses upwards and backwards to push the saliva down the throat. We swallow our saliva many times a day, and every swallow should be the same, lips sealed, teeth together and tongue on palate pushing up and back. And when we eat and drink, the exact same swallowing pattern is repeated. If the tongue posture is low during swallowing, not pressed against the palate, there is a tendency to use the face muscles around the mouth to create a suction to gather the saliva. This introduces two problems. 1. The lips and cheeks sucking on the teeth places an inward force on the teeth. If the force, which should be applied to the palate by the tongue during every swallow, is absent during childhood and adolescence, the growth forces of the maxilla are unopposed and the growth pattern is deformed. Chapter 5. Bones of the jaws. The underlying bones of the jaws consist of the zygomatic arches and maxilla, upper region, and the mandible, lower region. These bones need physical stimulation from the activity of the muscles of mastication in order to fully develop. Zygomatic arches. The zygomatic arches, also known as the cheekbones, are prominent structures of the face that play an essential role in facial aesthetics and function, contributing to the appearance of high cheekbones and a well-defined jawline. They form the lateral boundaries of the orbit, eye socket, and provide attachment points for several muscles, including the masseter muscle. The zygomatic arches have several functions, including providing structural support for the face, protecting the eyes and the temporalis muscle, and facilitating chewing and speaking. The zygomatic arches provide the attachment point for the masseter muscle, which originates from the lower surface of the arch and attaches to the angle of the mandible. The temporalis muscle, which originates from the temporal fossa and attaches to the coronoid process of the mandible, passes through the arch. The muscle and bone relationship. Since the temporalis muscle passes through the zygomatic arch, it follows that the more developed this muscle is, the wider and more prominent the arch will be. The tension on the arches caused by the pulling effect of the masseter muscles during tough chewing causes the arches to strengthen and grow to withstand the forces. The maxilla. With regards to proper facial development, the most important bone to consider is the maxilla. The maxilla is in direct contact with all of the facial bones and indirect contact through the teeth with the mandible. The maxilla is a vital component of the human skull, forming the upper jaw and playing a crucial role in facial development and growth. It is made up of two halves which are joined together at the midline suture. The maxilla grows continuously throughout childhood and adolescence, and its growth is a complex process influenced by various genetic and environmental factors. During this time, the maxilla grows in several directions, including forward, upward, and outward. During this growth stage, due to the presence of growth hormone, some natural growth is guaranteed. However, the direction and pattern of growth is governed by the forces acting on it by the action of the muscles. As the maxilla grows, it undergoes several changes in shape and structure. These changes are necessary to accommodate the developing teeth and provide proper support for the facial structures. For example, the maxilla develops two large cavities known as the maxillary sinuses, which form part of the air conditioning system of the nasal passages. The muscle and bone relationship. The muscle that has a major influence on the development of the maxilla is the tongue. The resting position of the tongue on the palate provides a small but continuous force on the maxilla. With every swallow, about 900 times per day, the pressure is momentarily increased. The tongue also places a force on the teeth of the upper dental arch, which causes them to move outwards to expand the arch. These forces of the tongue, together with the force transmitted to the bone during hard chewing, are responsible for directing the growth of the maxilla. The maxilla widens and strengthens in response to the forces. In the absence of these forces, when the tongue is not against the palate and when there is no strenuous chewing, the growth is downward. The maxilla becomes elongated vertically, the dental arch remains narrow, and the airways do not develop appropriately. The mandible. The mandible, also known as the jawbone, is the largest and strongest bone in the human face. It is a U-shaped bone that articulates with the temporal bones of the skull at the temporomandibular joints, allowing for movement of the jaw during chewing and speaking. The horizontal part of the mandible is called the body, and the vertical branches that extend upwards to meet the temporal bones are called the ramus. A poorly formed mandible has a dramatic effect on the appearance of the face, especially from a side profile. The muscle and bone relationship. Ideally, the mandible grows at the same rate as the maxilla. The force transmitted from the upper teeth during chewing and normal contact dictate and maintain the position of the lower teeth. The buccal, outward, facing cusp slopes of the maxillary molars contact the lingual, inward, facing cusp slopes of the mandibular molars. The resultant force pushes the lower teeth outwards. This causes outward growth of the mandible and ensures proper occlusion of the teeth all throughout the growth phase. The pulling effect of the masseter muscle, which attaches to the ramus of the mandible, causes the mandible to grow and strengthen to be able to withstand these forces. A well-developed mandible will have a squarer angle between the body and the ramus. Another crucial factor influencing growth is nutrition. Adequate nutrition is essential for proper bone growth and development. Nutrients such as calcium, vitamin D, and protein are particularly important for bone health and growth. Chapter 6. Breast is best. The preceding chapters have alluded to the importance of 3 behaviors that are absolutely vital for the development of the facial bones and musculature. These behaviors are: 1. Nasal breathing. 2. Correct resting tongue position. 3. Correct swallowing pattern. These behaviors are naturally instinctual from birth and are greatly developed during breastfeeding. Breastfeeding offers numerous benefits for both the infant's overall health and their facial development. Here are some ways in which breastfeeding can positively impact facial development. 1. Jaw and muscle development. Breastfeeding requires the baby to use their facial muscles, including the jaw, tongue, and cheeks, in a coordinated manner to achieve a latch. The latch is maintained by the action of the facial muscles and tongue pressing firmly upwards. This promotes the development of these muscles and helps in the proper alignment of the jaw, leading to a well-formed and properly functioning oral cavity. 2. Oral motor skills. The act of breastfeeding involves a variety of oral motor movements, such as suckling, swallowing, and tongue coordination. These movements contribute to the development of the oral motor skills necessary for proper speech development and the ability to chew solid foods later on. 3. Facial bone structure. Breast milk contains various growth factors, hormones, and nutrients that aid in the optimal development of the infant's bones and facial structure. The natural jaw movements during breastfeeding stimulate the growth of the bones in the face, promoting proper alignment and symmetry. 4. Prevention of non-nutritive sucking habits. Breastfed babies develop a strong and efficient sucking reflex, which helps satisfy their oral needs. This reduces the likelihood of developing non-nutritive sucking habits like thumb sucking or pacifier use, which can negatively impact facial development when prolonged. 5. Optimal nutrition. Breast milk is uniquely designed to provide all the necessary nutrients for a baby's growth and development. It contains an ideal balance of proteins, fats, carbohydrates, vitamins, minerals, and antibodies, which support overall health, including proper facial development. 6. Prevention of bottle feeding related issues. Bottle feeding, especially with a bottle nipple that doesn't promote natural sucking patterns, can increase the risk of issues like tongue thrusting, improper jaw alignment, and inadequate oral muscle development. Breastfeeding eliminates these potential problems, supporting optimal facial development. The introduction of bottle feeding, even intermittently, can cause confusion. The flow rate out of the bottle is usually greater and more consistent. The baby suddenly doesn't have to use the facial muscles or the tongue as much. Less effort required. The baby may prefer the bottle because of this and turn away from the breast when offered. This can disrupt the establishment of a successful breastfeeding relationship between mother and baby. The general recommendation is that babies are exclusively breastfed for the first 6 months. Thereafter, solid foods are slowly introduced. Breast milk remains the primary source of nutrition and calorie intake for the first 2 years. Breastfeeding beyond 2 years can do no harm. Mothers and their infants can enjoy the numerous benefits of breastfeeding for as long as it is convenient. After age 2, toddlers are usually able to gain sufficient nutrition from the food they eat. Our ancient ancestors lived in conditions of food scarcity. In such conditions, it would not be uncommon for children to be breastfed well beyond age 3. During a breastfeeding session, several therapeutic behaviors are developed and reinforced. These behaviors are: 1. Nasal breathing. While a baby is latched onto the breast, there is no chance of mouth breathing for long durations of time. 2. Tongue position and posture. The tongue is pressed upwards, against the nipple, towards the palate. 3. Swallowing pattern. In order to maintain the latch, the baby swallows while maintaining the upward tongue pressure. Transitioning from breastfeeding to cup drinking. Suckling and sucking should start and end with breastfeeding. Bottles and sippy cups with teats, straws, and spouts that are sucked by the infant should be avoided. These cups encourage low tongue posture and undo the good tongue posture and swallowing patterns that have been established during the breastfeeding stage. Ideally, the infant should gradually transition from breastfeeding to an open cup. Chapter 7. Infant-led weaning. Infant-led weaning is the natural approach to introducing solid foods to infants. It allows them to take control of their eating and self-feed from the beginning, rather than relying on spoon-feeding purees. It emphasizes the development of independent eating skills and encourages babies to explore and enjoy a wide variety of nutritious foods. Milk remains the primary source of nutrition for babies in their first 2 years of life, and solid foods are introduced gradually as complementary to milk feeds. The key principle of infant-led weaning is to introduce solid foods when the baby is developmentally ready, usually around 6 months of age. At this stage, infants have typically developed the necessary motor skills, such as being able to sit up with minimal support and having good hand-eye coordination, to handle solid foods. At this age, infants have a strong instinct to self-feed. Infant-led weaning encourages and develops this behavior. Instead of offering purees or mashed foods, parents practicing infant-led weaning offer appropriately sized and textured pieces of food that are easy for the infant to hold and manipulate. This can include soft fruits, dried fruits, cooked vegetables, eggs, beans, and small pieces of meat. The foods are presented in a way that allows the infant to grasp them with their hands and bring them to their mouth. Initially, this will be messy and very little food will actually be consumed. Gradually, the infant's dexterity increases and more food will be ingested by self-feeding. By allowing infants to self-feed and explore different textures, Infant-led weaning encourages the development of the muscles in the jaw and face and promotes a natural and gradual progression in the coordination of chewing and swallowing. This can contribute to the development of proper tongue posture, jaw alignment, and facial muscle strength. Chapter 8. Primary to permanent teeth. A skull or radiograph of an 8-year-old child interestingly shows that children at this age have a face full of teeth. From about age 6 to 12, the dentition is in a state of flux. There is a jostling for position. Deciduous teeth need to be shed and permanent teeth need to erupt into their final positions. The primary teeth, also known as baby teeth or deciduous teeth, play a crucial role in the eruption and development of permanent teeth. It is essential to care for primary teeth and address any dental issues promptly to ensure the healthy development of the permanent teeth. Here are some key reasons why primary teeth are important for permanent teeth eruption. 1. Space maintenance. Primary teeth act as placeholders for the permanent teeth that will eventually replace them. They help maintain proper spacing and alignment, ensuring that there is sufficient room for the permanent teeth to erupt in their correct positions. Premature loss of primary teeth due to decay or other factors can lead to crowding or misalignment issues when permanent teeth begin to erupt. 2. Guidance for eruption. Primary teeth guide the eruption path of permanent teeth. They help direct the permanent teeth into their correct positions within the dental arch. The roots of primary teeth serve as a guide for the developing permanent teeth, ensuring they erupt in the right sequence and alignment. The permanent teeth are much larger than the primary teeth, therefore it is imperative that there are spaces of at least 1 millimeter between the primary teeth. 3. Jaw development. Primary teeth aid in proper jaw development. They assist in the growth and development of the jaw bones, providing a stable foundation for the permanent teeth. The pressure exerted during chewing and biting on primary teeth stimulates the growth of the jaw bones, which is essential for accommodating the larger size of permanent teeth. 4. Speech development. Primary teeth play a role in speech development. They help children learn to pronounce sounds and words correctly. The proper alignment of primary teeth facilitates proper tongue and lip movements necessary for clear speech. If primary teeth are missing or misaligned, it can affect a child's ability to speak clearly. 5. Nutrition and digestion. Healthy primary teeth are vital for proper nutrition and digestion. They enable children to chew food effectively, breaking it down into smaller pieces for digestion. Inadequate chewing due to missing or decayed primary teeth can lead to stomach problems. Eruption sequence. The eruption order of the permanent teeth occurs in such a way so that the masticatory function is maintained. Teeth are lost and replaced gradually and systematically so that there is no disruption to eating, speaking, and facial growth. Every tooth that erupts joins an already functioning set. There is also no drastic remodeling of the jaw joint. Same joint, different teeth. For this systematic replacement and positioning of teeth to happen, it is imperative that the mouth is closed most of the time during childhood and adolescence with teeth in light contact. In this way, every tooth erupts until it meets its antagonist and its permanent position is established. A child with an open mouth posture can experience a partial over-eruption of some teeth and thereby creating premature contacts and deflective contacts. Teeth are not all occluding at once, as they should. Early loss of primary teeth. The enamel layer of primary teeth is thin. Beneath the enamel is dentin, which has very little resistance to decay. Once the enamel layer has a small cavity, the tooth destruction can progress rapidly. Parents are strongly advised to take care of their child's primary teeth and to avoid sugary foods and sweets. Most fruit juices are heavily laden with sugar, ascorbic acid, and citric acid, which are all extremely effective at dissolving enamel. Baby bottle tooth decay is a term given to early tooth decay. It is usually caused by prolonged bottle feeding. Baby formula, fruit juices, and even breast milk all contain sugars that can cause tooth decay. Babies and toddlers should not be put to bed with a bottle of sugary liquid. Chapter 9. Mouth breathing and the devastating lifelong consequences. Possibly the most harmful habit a child can adopt is a mouth breathing habit. A habitual mouth breather usually has their tongue resting at the bottom of the mouth, hypotonic, low tongue posture. A mouth breathing habit can severely affect the growth of the facial bones and almost certainly result in crooked teeth. The air that we breathe will always take the path of least resistance. Shortest, easiest route. Even if the mouth is open only slightly, the air will flow through the mouth and bypass the nasal passages. Other than eating and speaking, the lips should be perfectly sealed. Mouth breathing should be reserved for short durations of high-intensity exercise and emergencies. A mouth breathing habit can lead to a variety of problems, both physical and psychological. The following is a list of the possible consequences of mouth breathing. Physical. 1. Poor maxillary growth. If the tongue pressure is absent from the palate during childhood, the palate does not widen and remains narrow. The dental arch becomes V-shaped and the teeth will be crowded. The maxilla grows vertically. The face lengthens and flattens. 2. Poor nasal passage development. A narrow maxilla means that the nasal passages are also narrow. Narrow nasal passages become obstructed much easier and are more likely to be affected by allergies. 3. Poor air quality. Every breath is compromised. Nose breathing warms and filters the air to remove dust and pathogens. It also pressurizes the air and allows the lungs to draw more oxygen out. The passages of the nose release nitric oxide, an important neurotransmitter affecting gas transport. 4. Poor tongue tonicity. The tongue resting on the floor of the mouth becomes hypotonic. 5. Snoring. Due to poor tongue tonicity and constricted airways, the soft tissues collapse into the throat during sleep and this results in snoring. 6. Obstructive sleep apnea, a condition in which a person's airway becomes blocked while they sleep, causing them to wake up frequently. Due to the poor tongue tonicity, the tongue collapses into the airway during sleep, causing temporary suffocation and disrupted sleep. This can lead to poor sleep quality and daytime fatigue, as well as other health problems such as high blood pressure, heart disease, and stroke. 7. Poor overall growth. Children who are not reaching deep sleep are losing out on the stage when the growth hormone is secreted, and this can impact their height and weight. 8. Dry mouth. Dry mouth can lead to tooth decay and gum disease, as the lack of saliva makes it harder to neutralize plaque and bacteria. 9. Poor eyesight. The maxilla and zygomatic bone also forms a large part of the floor of the orbit, eye socket. A poorly developed maxilla and zygomatic bone is also underdeveloped in this region, causing a slight restriction of the eye socket. Astigmatism is a common eye problem caused by a slightly misshapen eyeball. This results in distorted or blurred vision. The size of the eyeball and the size of the teeth are genetically determined. The most likely cause of astigmatism is irregular eye development, which occurs because there is insufficient space for the eyeball to reach its full genetic expression. In children, the shape of the eye can change as they grow, which may cause the astigmatism to improve or worsen over time. 10. Poor mandibular development. Tooth-on-tooth forces, upper against lower, are not present and therefore the signal to grow and strengthen is not transmitted. 11. Over-eruption of teeth. Ideally, the teeth will erupt until they meet their antagonists, opposing teeth. When the mouth is open most of the time, the teeth will over-erupt, causing premature contacts and deflective contacts. Psychological. 1. Poor oxygenation. Mouth breathing can lead to poor oxygenation of the body, which can cause fatigue, headaches, irritability, and poor focus. 2. Behavioral and emotional disorders. Sleep apnea, also known as sleep-disordered breathing, can negatively impact growth, focus, and behavior. It is nearly impossible to reach stage 3 deep sleep when the body is not properly oxygenating. During an apnea event, which can happen up to 30 times an hour in severe cases, the body goes into fight or flight mode and wakes itself periodically to remain alive. This dramatically increases cortisol levels, stress hormone. The most common reasons for mouth breathing in children? 1. Obstruction in the nasopharynx or nasal passage is the most common cause of mouth breathing. This may include a deviated nasal septum, nasal polyps, enlarged bones or blood vessels. 2. Enlargement of the tonsils and adenoids, rhinitis, or inflammation of the nasal lining from causes such as allergy, infections, or other types of inflammation. 3. Another possibility is that the child has tongue tie, ankyloglossia. This happens when the tissue that attaches the tongue to the bottom of the mouth, lingual frenulum, is too short. Tongue tie can limit the movement of the tongue. This is a relatively easy thing to fix and in infants does not even require anesthesia. 4. Children tend to imitate and copy their parents' or caregivers' behaviors and tendencies. If children see their parents breathing through their mouths, they are very likely to copy this behavior. Chapter 10. The wrong diet. Human dietary patterns have undergone significant changes over time. Modern processed food, characterized by its convenience, affordability, and widespread availability, stands in stark contrast to the ancient Paleolithic diet. By examining the fundamental differences between these two diets, we gain valuable insights into the impact of food processing and its implications for modern facial morphology. The Paleolithic diet, often referred to as the hunter-gatherer diet, was primarily based on whole, unprocessed foods available to our ancestors during the Stone Age. Modern processed food is laden with artificial additives, preservatives, refined sugars, unhealthy fats, and excessive salt. The most significant difference between processed food and natural single-ingredient food is the toughness. Natural food requires much more chewing force and for much longer periods of time. Processed food, on the other hand, mostly dissolves in the mouth. People who follow a natural diet do the food processing with their masticatory system. The second important difference is the calorie content. Processed foods are made more palatable by adding high amounts of sugar, fat, and carbohydrates, which make them significantly more calorie-dense per weight and volume. Additionally, this sugary carbohydrate composition causes obesity and tooth decay. Another major difference between the historical hunter-gatherer way of eating and the modern way is the use of utensils. This hugely reduces the physical effort needed to eat. Many well-meaning modern mothers erroneously cut up their children's food into small bite-sized mouthfuls. This is the exact opposite of what is needed. Natural food has to be manipulated with the hands, lips, teeth, and tongue. The entire masticatory system is engaged and working. Food pieces are pulled, bitten, torn, crushed, and chewed. The jaw moves in all directions. All of the masticatory muscles are called into action. Besides the strenuous use of the masseter and temporalis for crushing and chewing, the lateral and medial pterygoid muscles are used to protrude the mandible. The lower incisors are the sharpest teeth in the mouth and are incidentally the first teeth to erupt in the primary dentition. One of the characteristics of natural eating, which is absent from utensil eating, is the precise and deliberate use of the lower incisors to strip and scrape meat from bone, or fruit from peels, etc. Examples of modern processed soft foods: puree, powdered foods, yogurt, cereals, puddings, cakes, processed meat, sandwich meats, hot dogs, French fries, noodles, porridge, peanut butter, ice cream, waffles, pork sausages, pies. Examples of natural single-ingredient foods: dried meat, berries, fish, fruit, cooked fat, meat, raw carrots, sugarcane, corn on the cob, whole nuts such as almonds and walnuts, seeds, beef, pork, licorice, chicken, dried fruit. Chapter 11. Parafunctional habits. Parafunctional habits are oral movements or actions which are completely unnecessary and introduce severely disruptive and damaging forces. These habits can have an extremely detrimental effect on the oral structures in young children and adults. At any stage of life, the equilibrium of the oral structures can be disrupted by the addition of some or other foreign object or unwanted force. In growing children, the bone is surprisingly malleable, and even a light force can cause considerable deformation if it is repeatedly applied. The anterior, front, teeth are more easily affected by pressures and forces because they have smaller roots and less surrounding bone. Anterior teeth are easily tipped forward or backward because the adjacent teeth provide no support in that direction. These habits are usually unconscious and normally require some practical intervention in order to be corrected. A detrimental habit must be addressed promptly to avoid any long-term damage. A child may eventually grow out of a habit, but by that time the structures may already be permanently deformed. A habit-breaking appliance, available from a dentist or dental laboratory, is a removable appliance which has wires and other components which provide a physical barrier, making the habit impossible. Alternatively, a habit such as thumb sucking can be stopped by doing something as simple as putting a bandage or glove on the thumbs. A habit can be stopped in as little as 2 weeks. Examples of parafunctional habits are: 1. Thumb sucking. 2. Tongue thrusting. Tongue is thrust forward between the anterior teeth. 3. Tongue biting. Tongue is habitually placed between the teeth or during swallowing. 4. Teeth grinding. Also known as bruxism, usually occurs at night when asleep. 5. Nail biting. 6. Cheek biting. 7. Lip biting. 8. Teeth clenching. These habits are not acceptable at any stage of development. A thumb-sucking habit is possibly the most damaging and also the easiest for parents or caregivers to detect. The pressure of the thumb on the anterior teeth causes the upper teeth to flare outwards and the lower teeth to tilt inwards, and the underlying bone growth is deformed. Besides the detrimental effects, the habit also negates the positive effects of having correct tongue posture, tongue on the roof of the mouth. Many parafunctional habits are unconscious compensatory mechanisms. These compensatory mechanisms occur because there is a masticatory system imbalance or some other functional inadequacy. Teeth grinding during sleep, for example, may be an unconscious attempt by the body to 1. Modify the teeth to improve occlusal function. 2. Put to use the masticatory muscles which are not being used enough during the day. 3. Move the jaw and tongue forward to open the airway to improve breathing. Tongue biting and tongue thrusting, for example, may indicate that there is insufficient space for the tongue in the mouth. Chapter 12. How teeth move through bone. Bone is living material that is constantly being broken down and replaced. The process of bone growth is called osteogenesis. New bone is deposited by cells called osteoblasts and old bone is resorbed by cells called osteoclasts. Here are some interesting facts about tooth movement. 1. The process and ability of tooth movement through bone is necessary for the eruption of the teeth, and this natural ability and tendency is utilized in orthodontics to move teeth. 2. Tooth eruption is preceded by osteoclast activity in the eruption path. Bone is demineralized and becomes porous and resorbs. 3. Teeth will drift from an area of high bone density to an area of low bone density. 4. Teeth will naturally drift into open spaces and over-erupt if there is no antagonist. 5. Tooth movement through bone is only possible because of the periodontal ligament. The periodontal ligament is the elastic shock absorbing interface between tooth and bone. It is strongly attached to the bone and tooth. 6. Children have less dense and more porous bone compared to adults. The rate of bone remodeling is also much higher. Due to these physiological differences, tooth movement by natural and orthodontic means is significantly easier in growing children compared to adolescents and adults. When a force is applied to a tooth by the tongue, lips, or orthodontic wire, the tooth moves ever so slightly because of the elastic nature of the ligament, but the equilibrium is disrupted. The periodontal ligament is stretched on the one side and compressed on the other. The stretching causes tension on the bone. This tension causes bone deposition in this area, osteoblast activity. The compression of the ligament on the other side creates an area of high pressure and the bone is resorbed, osteoclast activity, and equilibrium is restored. This process is repeated many times and tooth movement is achieved. It is important to note that new bone is spongy and porous, low density, and old bone is compact and hard, high density. If the applied force is suddenly removed, the tooth will slowly return to its original position so that equilibrium is restored. Chapter 13. The problem with traditional fixed orthodontics. The application of well-directed forces onto the teeth enables the orthodontist to move the teeth into whichever direction necessary to improve function and aesthetic harmony. Fixed orthodontics can, of course, only be attached when the majority of the permanent teeth have erupted. In almost all cases, the orthodontist is presented with a patient somewhere between 11 and 15 years old, with anterior crowding, poor molar relationships, and poor occlusal function. The reason for this misalignment of teeth is usually due to consistently poor maxillary and mandibular bone growth, from infancy to adolescence. The result is a patient who just simply doesn't have enough room for all of the teeth to be aligned in their proper positions. Unfortunately, fixed orthodontics cannot address the many years of poor facial development. Instead, the focus of traditional fixed orthodontics is purely on the teeth. In many cases, the orthodontist has no choice but to extract teeth, usually the premolars and third molars, in order to create enough room. In so doing, facial volume is greatly reduced, total tooth and bone volume is reduced. In some cases, the orthodontist will retract, push towards the back of the mouth, the maxillary teeth to align with a poorly developed and retruded mandible. This is known as camouflage orthodontics. Some teeth are moved and others are removed to compensate for an underlying skeletal discrepancy between the upper and lower jaws. This creates a somewhat aesthetic smile, but the face remains deformed and underdeveloped. Any airway and breathing issues are not addressed and in some cases may even be worsened. There may be many reasons why a person may want to avoid traditional orthodontics. The following are some of the main concerns. 1. Downward growth. Under normal circumstances, the maxilla continues to grow and strengthen until age 14. The highest percentage of growth occurs in the last 2 years, age 12 to 14. Chapter 3 discusses the importance of the forces transmitted through the teeth to achieve full maxillary growth. The preteen and early teen years would therefore be the absolute worst time to have the teeth bound together. Binding the teeth together mutes the forces from the tongue and from tough chewing. The outward growth of the maxilla is arrested and downward growth is accelerated. The face is visibly lengthened. The effects on the maxillary morphology are the same as those from habitual mouth breathing. 2. Disruption of balance. Though a person may have crooked teeth before treatment, the masticatory system is in a state of equilibrium. Growth and development have occurred naturally and nature, all of the forces at play, has placed things in the best way possible. Rearranging the teeth with mechanical means disrupts this balance and may affect some other component of the system, such as the jaw joints. 3. Aged appearance. One of the characteristics of an aging face is a reduced facial volume. Removing teeth and the subsequent loss of surrounding bone causes a reduction in facial volume. This is of little consequence when the patient is young, but comes to bear later on in life as the patient gets older. 4. Permanent retention. Since the teeth have been mechanically moved out of their positions of equilibrium, it is a certainty that they will return to their original positions once the orthodontic forces are removed. The results of traditional orthodontics are temporary and unstable. The only way to prevent the teeth from relapsing to their original positions is with permanent retention. This is done by placing a fine braided wire on the lingual surfaces of the anterior teeth, fixed retainer. Alternatively, the patient can opt to wear an appliance at night during sleep, removable retainer. Both of these options are problematic in the long term. Fixed retainers are more comfortable and don't require the patient to remember to use them, but are prone to breaking and debonding from the teeth. They require the person to be constantly aware of the retainer and to be careful when biting and chewing hard foods. Such a person has a reduced functionality and has to avoid certain foods. Removable retainers, on the other hand, require the patient to wear them every night for the rest of their lives. If 1 or 2 nights are skipped, the teeth move back slightly, and when the appliance is worn again, it can be uncomfortable and painful. Both of these methods require a lifelong commitment. For many people, this commitment is just too bothersome and they abandon the retainers entirely. The teeth slowly but surely move back to their positions of equilibrium. Chapter 14. TMD on the rise. Many people suffer with a debilitating condition known as temporomandibular disorder. This is a disorder of the jaw joint. The symptoms of this disorder are joint pain, headaches, and muscle soreness. Due to the close proximity to the ear canal and the abundance of nerves in this small area, TMD pain can often be incorrectly perceived as earache. There may be various possible causes of joint disorders such as arthritis, congenital deformities, lack of synovial, lubricating, fluid, trauma, or overuse of muscles. The majority of TMD cases are, however, caused by a developmental disharmony between the temporomandibular joint and the dental occlusion. The jaw joint is a type of ball and socket joint that is able to move side to side, forward and backward, and rotate as a hinge. The ball of the joint is known as the condyle. The condyles are held in position by muscles, ligaments, and tissues. When all the muscles, ligaments, and tissues are completely relaxed, passive stability, the position of the mandible relative to the maxilla is known as centric relation. In this position, the teeth are in light contact. During hard biting or clenching, the teeth are in a position called maximum intercuspal position. For most people, 90% of modern humans, when they bite hard, their teeth first contact, then slide into maximum intercuspal position. In order for the teeth to be in this maximum intercuspal position, the jaw joint is pulled slightly out of its most comfortable position. For the condyle position in the joint, there is a slight discrepancy between centric relation and maximum intercuspal position. The greater the discrepancy, the greater the probability of temporomandibular disorder. During maximum intercuspation, the condyle may have to move slightly forward or backward. If the movement is forward, the small lateral pterygoid muscle may be in constant tension. If the movement is backward, the tissue behind the condyle, known as retrodiscal tissue, may be compressed. If the duration of displacement is short, such as during chewing, there is little or no consequence. But if the joint is held in this position for prolonged periods of time, such as during clenching or bruxism, teeth grinding, while asleep, severe pain may result. This pain is caused by inflammation, which places pressure on the nerves. The inflammation doesn't subside immediately as soon as the clenching stops. There is usually a dull lingering pain throughout the day and may be more severe in the morning. Bruxism may be an unconscious attempt by the body to modify the teeth to reduce the discrepancy between CR and MIP. Fortunately, the jaw joint is able to adapt and remodel over time. The shape of the condyle is altered by osteoblast and osteoclast activity. Remodeling of the jaw joint can only be successful and therapeutic if the condyles are in the correct position for most of the time. This position is centric relation, with teeth in light contact. Where is your mandible? The mandible can be held in 3 positions. 1. Open, no contact between upper and lower teeth. 2. Centric relation, teeth in light contact. 3. Maximum intercuspation, occurs during hard biting and chewing. It is perfectly normal to spend a portion of the day with the mandible in all 3 of these positions. A disproportionate amount of time spent in a day in the wrong position can have major consequences on the alignment of the teeth and the possibility of TMD issues. Figure 14.2.1 shows an example of a normal healthy ratio. Most of the time, the mandible is held in centric relation. In this example, the mouth is only open during eating and speaking and closed for the rest of the time. The teeth are in maximum intercuspation only during chewing. Such an individual will most likely have well-aligned teeth and no TMD issues. Considering that 90% of modern humans have a discrepancy between centric relation and maximum intercuspation, requiring slight compensatory movements of the condyles when their teeth are in maximum intercuspation, it is imperative to limit the amount of time spent in that position. Figure 14.2.2 shows an example of an individual who is spending a disproportionate amount of time with the teeth in maximum intercuspation. Such an individual has either daytime clenching or bruxism while asleep, and will very likely suffer from dental attrition and TMD issues. Chapter 9 discusses the importance of having teeth in light contact and discusses the devastating consequences of mouth breathing, no contact between upper and lower teeth. Figure 14.2.3 shows an example of a mouth-breathing individual who spends a disproportionate amount of time with no teeth in contact. Such an individual is very likely to have a low tongue posture and will almost surely suffer with malocclusion, inefficient breathing, sleep apnea, and possible TMD issues. Figure 14.2.4 shows the worst-case scenario. Habitual mouth breathing, with no teeth in contact and a disproportionate amount of time in maximum intercuspation due to clenching or bruxism. Such an individual will suffer with malocclusion, inefficient breathing, sleep apnea, dental attrition, and very likely TMD issues. Chapter 15. Is your smoking ruining your child's face? The negative consequences of mouth breathing have been described in Chapter 9. With this information in hand, it is imperative that we never place children in an environment in which the air is irritating, noxious, or smells unpleasant. A child will instinctively switch to mouth breathing to avoid the irritation of the sensitive nasal linings. A child that is constantly exposed to these irritants will quickly develop a mouth-breathing habit with a low tongue posture and suffer all of the aforementioned consequences. Additionally, people who smoke are themselves at high risk of developing a mouth-breathing habit because the smoke is repeatedly inhaled and exhaled through the mouth. This behavior can become the habitual way to breathe even when not smoking. Chapter 16. Myofunctional therapy. Myofunctional therapy is a series of facial exercises designed to train and strengthen the orofacial and masticatory muscles to improve muscle tone and function. The word myo is derived from the Latin word myos, which means muscle. When there are abnormalities or imbalances in these muscles, it can lead to a range of issues, including improper facial development, speech disorders, and sleep-disordered breathing. These exercises can be done at any age, but are particularly important for young children who have not completely developed their muscles and muscle tone. This therapy serves to develop and reinforce the good habits. The goals of myofunctional therapy are: 1. Identify any problems. If a child is unable to do one or more of the exercises, it is possible that there may be a physical reason for this. For example, if a child is unable to place the tongue on the palate, the child may be tongue-tied, or if a child is unable to breathe through the nose with the mouth closed, there may be a nasal obstruction. These abnormalities can be easily remedied by an ENT surgeon. 2. Improve muscle coordination and muscle tone and establish proper functional habits. These exercises typically target specific muscles in isolation. 3. Establish proper speech patterns. Tongue position and tongue control is vital for forming a full range of sounds and perfecting pronunciation. 4. Establish proper swallowing patterns. A normal healthy swallow occurs without the recruitment of the orofacial muscles and lips and without developing a suction. The tongue is placed flat on the palate and moves up and slightly backward during the swallow. Using the facial muscles and lips with every swallow can be seen as a parafunctional habit. Over time, the small unwanted inward forces caused by these swallowing habits can restrict the growth of the maxilla and mandible and also tilt the teeth inwards. 5. To achieve proper posture of the tongue, head, and neck, which is essential for growth and efficient breathing. 6. Establish an unconscious lip seal. People who habitually close their mouths with their lips perfectly sealed are likely to continue this behavior even while asleep. 7. Establish a teeth in light contact posture. In order to develop a functional occlusion, the teeth need to be in light contact most of the time. The permanent teeth erupt and move into their final positions when they meet their antagonists. 8. Establish nasal breathing. The therapy is usually carried out by a trained myofunctional therapist who assesses the patient's specific needs and designs a personalized treatment plan. This therapy can be started at age 3. The therapist guides the individual through exercises and techniques, teaching them how to correctly position and use their tongue, lips, and other orofacial muscles. Alternatively, these exercises can be done at home. There are many videos and tutorials available which show the exercises and techniques. Obviously, these myofunctional therapies were never part of ancient human life and may not be necessary for everybody. The exercises are relatively simple and easy to do. They can only be beneficial and can cause no harm. The therapy is an additional safeguard against poor habits and poor swallowing patterns, and most importantly can help detect any problems early on. Myofunctional appliance. In addition to the myofunctional exercises, it can be helpful to use an appliance. A myofunctional appliance is a series of prefabricated soft plastic appliances available in graduated sizes. This appliance is worn at night during sleep. This is sometimes called a pre-orthodontic appliance and can be worn from age 4. The functions of such an appliance are to 1. Encourage the jaws to grow with a proper maxillary and mandibular relation. 2. Encourage nasal breathing. 3. Encourage good tongue posture. Chapter 17. Natural and healthy forces and their effects on the masticatory system. It is important to note that all of the forces can act simultaneously. Small forces applied over long periods of time can have significant results. Denying these beneficial forces can severely affect the developmental growth and final adult morphology of the maxilla, mandible, masticatory muscles, and the jaw joints. Counterbalancing forces. Some of the forces are counterbalancing. These counterbalancing, opposing, forces need to be equal to each other in order to achieve equilibrium. When a counterbalancing force is removed, the antagonist force is unopposed and the structures are rearranged until an equilibrium is achieved. In Chapter 4, Figure 4.2 shows the counterbalancing forces of the lips and cheeks and the tongue. If the lips are removed from the equation, such as when a person has an open mouth posture, the force of the tongue is unopposed and the teeth will flare outwards, resulting in buck teeth. If the force from the tongue is non-existent, such as when a person has a low tongue posture, hypotonic lazy tongue, on the bottom of the mouth, then the teeth will tilt and drift inwards due to the unopposed forces of the lips and cheeks. Growth potential. During the growth phase, bone and muscle growth is directed by function. From infancy to adolescence, every bone cell has growth potential in all directions. Tensile stress, pulling force, accelerates bone growth in the direction of the stress. Compressive stress, pushing force, restricts bone growth in the direction of the stress. State of equilibrium. Figure 17.2 shows how each tooth is in a state of equilibrium. There are forces present from 6 different directions. The forces are all of such an equal magnitude that they cancel each other. These forces are 1. Occlusal forces from tough chewing. 2. Eruption forces. 3. Adjacent tooth forces on both sides of the tooth. 4. Tongue forces. 5. Lip and cheek forces. Force vectors. Figure 17.3a shows the force vectors that are transmitted throughout the maxilla during tough chewing. The occlusal forces become compressive stress. And since the stress is divergent, it creates tensile stress in the bone. This tensile stress greatly influences the growth pattern of the bone. Figure 17.3b shows how the continuous force from the tongue prevents excessive downward growth of the maxilla and promotes outward growth. Optimal growth directed by function. Figure 17.4 shows a coronal diagram at the level of the first permanent molars. List of the beneficial forces and the results. 1. Tongue applies a constant force on the palate. Result A. Palate expands outwards and becomes wider. B. Nasal cavity widens. C. Forward growth of the maxilla. D. Prevents excessive downward growth of the maxilla. E. Tongue develops good tongue tonicity. 2. Tongue applies a constant force on the palatal surfaces of the maxillary teeth. Result F. Teeth move outwards and the dental arch expands. G. Counteracts the forces from the lips and cheeks. 3. Biting force during tough chewing. Result H. Force is transferred through the teeth to the surrounding bone. I. Bone growth is accelerated and bone strengthens. J. Bone around roots increases, prevents sinus drop. K. Mandible grows forward, widens and strengthens. 4. Masseter muscle contracting during tough chewing. Result L. Ramus of the mandible enlarges. M. Ramus becomes more square. N. Ramus width increases. O. Zygomatic arches enlarge and strengthen. P. Masseter becomes well developed. 1. Tooth-on-tooth forces during chewing in natural, teeth in light contact, posture. Result Q. The positions of the mandibular premolars and molars are maintained by the position of the maxillary molars and premolars, upper buccal facing cusp slopes contact lower lingual facing cusp slopes, forcing the lower teeth to move outward in order to achieve and maintain a functional occlusion. The maxilla and mandible grow and develop together at the same rate. Chapter 18. When to intervene. Chapter 8 discusses the important role that the primary teeth play in the development of the adult dentition. Another important function of the primary teeth is that they continuously provide an indication of the developmental progress of the growing masticatory system. A professional developmental assessment can be done by a dentist at age 6. At this age, there should be certain features present. A poorly developing child will have characteristic telltale signs that indicate a strong possibility of problems in the future. During such an assessment, some of the things the dentist will look at are: 1. Arch development. The dental arch and underlying alveolar bone should be U-shaped and not V-shaped. A narrow and V-shaped arch is an indication of poor maxillary growth. 2. Molar relationships. The first permanent teeth to erupt are the first molars. This usually happens at age 6. The occlusal relationship of the first permanent molars, maxillary against mandibular, can have a dramatic influence on the development of the occlusion. Malocclusion is sometimes defined and classified according to the particular occlusal relationship of the first molars. An unfavorable relationship can quite accurately predict the eventual outcome and adult facial appearance. 3. Occlusal function. All teeth should contact simultaneously when teeth are in light contact. 4. Spacing. There should be spaces of at least 1 millimeter between all of the primary teeth. Permanent teeth are always bigger than the primary teeth and will need more space than their predecessors. 5. Crowding. If the primary teeth are crowded without sufficient space between the teeth, it is almost a certainty that the permanent teeth will be crowded. 6. Vertical dimension. Excessive downward growth of the maxilla will produce the characteristic gummy smile. This is known as vertical maxillary excess, VME. Vertical maxillary excess produces an occlusal plane that is lower than expected and an elongated appearance to the lower half of the face. 7. Deep bite. In the primary dentition, when the teeth are together, approximately 80% of the lower incisors should be visible. 8. Extra teeth. In some cases, there may be one or more of the same tooth. This is known as a supernumerary tooth. A supernumerary tooth will affect the normal eruption and alignment of the surrounding teeth and may need to be extracted. 9. Missing teeth. In some cases, there may be a complete absence of one or more teeth. This is known as hypodontia. In such a case, the teeth adjacent to the area of the missing tooth will drift into the open space and affect the occlusal function and aesthetics. 10. Underbite. The lower anterior teeth should occlude behind the maxillary anterior teeth. 11. Anterior crossbite. The incisal edges of the maxillary teeth should always occlude beyond the mandibular incisal edges. 12. Posterior crossbite. The buccal cusps of the maxillary teeth should always occlude beyond the mandibular buccal cusps. 13. Overbite. This is also known as overjet. This is an occlusal discrepancy between the maxillary incisors and mandibular incisors, where the maxillary teeth appear too far forward. This usually occurs because the mandible is retruded too far back. In such a case, the mandibular incisors do not occlude with the maxillary incisors and will over-erupt. Similarly, the maxillary incisors do not occlude with the lower incisors and also over-erupt because there is no occlusal contact. 14. Eruption progress. The normal eruption order of the teeth and the age at which each tooth develops and erupts is very similar for most people. There is an established sequence of events. An assessment at age 6, including radiographs, will determine if everything is on track. 15. Impacted teeth. Radiographs will show if there are any impacted or poorly orientated teeth preventing normal eruption. 16. Anterior open bite. This can be due to a skeletal deformation and lack of eruption progress, usually caused by a parafunctional habit such as thumb sucking, tongue biting, or tongue thrusting. This can also be caused by the overuse of pacifiers, teething rings, etc. 17. Decay and attrition. Early loss of primary teeth caused by decay can be problematic because the remaining adjacent teeth will drift from their intended position in open space and cause a disruption to normal tooth eruption paths. Tooth destruction and attrition will indicate that there may be a parafunctional habit such as bruxism or clenching. At this assessment, the dentist can determine whether the child will benefit from early intervention therapy to address poor developmental progress. This poor development is usually caused by a lack of the beneficial forces or an imbalance of forces. Chapter 19. Early intervention. This type of treatment is slowly gaining in popularity and is increasingly falling into the domain of general dentistry. With the use of an orthopedic dental appliance, an early intervention interceptive treatment can change the growth trajectory. A series of appliances accelerate bone growth and tooth movement to make up for poor developmental progress. Early intervention must take place during the high growth phase, age 6 to 10, of the mixed dentition. Some permanent and some primary teeth still present. The treatment should start at age 6 or 7. It is important to note that an early intervention treatment does not aim to straighten the teeth. The appliances place forces on the primary and permanent teeth and on the soft tissues of the palate to guide facial bone growth and development to provide enough space for the permanent teeth to erupt correctly. Functions of early intervention. 1. Eliminate unwanted forces. An appliance can be fitted with buccal shields to eliminate inward forces from cheeks and lips. 2. Expand the maxilla. During the high growth phase, age 6 to 12, an expansion appliance, which places force on the teeth, will cause the maxilla to grow at the midline suture and achieve some outward bodily growth. There may also be some movement of the teeth in the bone. The appliance rapidly achieves the bone growth and tooth movement that should have occurred due to the pressure of the tongue on the palate. 3. Increase forward growth of maxilla. By applying forces to the front teeth and the anterior portion of the palate, the appliance causes the maxilla to grow in length from front to back. This dramatically increases the alveolar length, which creates more space for the teeth. An expanded and widened arch also creates more tongue space. 4. Expand the mandible. During the expansion phase of the treatment, a lower expansion appliance can be used to expand the lower arch. This assists and promotes normal mandibular growth. 5. Advance the mandible. If unfavorable molar relationships have been established and the mandible is set back, it is highly unlikely that the condition will autocorrect. The lower dentition is locked into a retroude position. Every time the teeth contact, this occlusal relationship is reinforced and maintained. There are several ways to correct this. An appliance which has a bite plane that disengages the upper and lower teeth allows the mandible to slide and advance forwards and grow to its maximum potential. A function-regulating orthopedic appliance engages the upper and lower jaws. It holds the mandible in a more optimum position so that normal mandibular growth can occur. 6. Stop any parafunctional habits. Any damaging habits that have been allowed to progress until this age must be stopped immediately. Habit-breaking components can easily be included in a removable appliance. 7. Correct any crossbite. A posterior crossbite can be corrected by either expanding the maxillary or mandibular arch. An anterior crossbite can be corrected by placing targeted forces onto individual teeth. This is done with springs or screws built into the appliance. 8. Correct open bite. An anterior open bite is usually caused by tongue biting or tongue thrusting. An appliance that includes a habit-breaking component will prevent any possibility of tongue biting or tongue thrusting. 9. Correct function and posture. Poor facial development is usually caused by the lack of the beneficial forces or an imbalance of forces. Some of the positive gains achieved by early intervention treatment will be lost if the posture of the tongue and the swallowing patterns are not corrected. A final phase of treatment includes a posture-correcting appliance which a. Trains the child to swallow without using the face muscles. b. Trains the child to keep the lips sealed. c. Trains the child to keep their tongue on the roof of the mouth. d. Trains the child to keep the teeth in light contact. These behaviors need to be unconscious and automatic so that all of the orofacial forces are permanently in a state of equilibrium. Types of early intervention appliances. There are many types of appliances, the appliances fall under two main categories: fixed and removable. The advantage of a fixed appliance, such as a rapid palatal expander and a light wire appliance, is that they are cemented onto the teeth and therefore don't require any compliance from the child. The disadvantage is that they have less capabilities compared to the removable appliances. The removable appliances can include expansion components, lip bumpers, bite planes, springs, etc. Another benefit of removable appliances is that they are periodically removed and reinserted throughout the day, during eating and cleaning, which provides an intermittent disruption of the applied forces. This is a more physiological and natural way to promote bone growth and teeth movement. The first phase of treatment usually involves the use of an expansion appliance, which contains a centrally located expansion screw. The screw is turned slowly at daily or weekly intervals. During the high growth phase, age 6 to 12, significant change can easily be achieved. The bone growth patterns are directed in such a way to produce the best possible adult morphology. These appliances are usually very well tolerated and don't cause any pain or discomfort because the forces applied are light. The problem with most of these appliances is that they place material on the lingual surfaces of the teeth and on the palate. This is not ideal because the appliance interferes with the normal tongue posture and swallowing patterns. A final phase of treatment should therefore always include a posture-correcting appliance to reinstitute all of the good behaviors, particularly correct tongue posture. Once the appliance therapy phase is completed, and the bone growth and development has been sufficient, the child should work closely with a myofunctional therapist to ensure correct resting posture and swallowing patterns. Another concern is that a child's dentition is constantly changing. A poorly fitting appliance is much less effective. The child's bone growth progress and appliance fit during therapy needs to be closely monitored with regular checkups. Chapter 20. A timeline of events. In order to ensure optimal growth progress from birth to adolescence, it is imperative that correct and natural development is allowed to occur. Parents are encouraged to practice normal and natural parenting that is consistent with their child's physiological developmental needs at the appropriate age. If it is found that the child is not developing correctly and that there is a good possibility of problems in the future, an early intervention treatment can be sought. These practices and interventions can contribute to a child's overall well-being and set the foundation for a lifetime of good oral health. Every child may develop slightly differently, but the general guidelines are as follows. Tongue tie. A doctor or nurse can check for tongue tie in the first week. Babies who are tongue-tied may have difficulty latching onto the breast and may also struggle to form a seal around the breast, causing milk to leak out of the mouth. A frenectomy is a relatively simple and painless procedure. The doctor transects the frenulum to release the tongue so that the baby is able to have full movement and use of the tongue. Breastfeeding. In order to gain the maximum benefits from breastfeeding, babies should be breastfed for at least 24 months. Infant-led weaning. Ideally, infants should be allowed to attempt to self-feed from about 6 months old. At this stage, and for the next few months, almost all of the nourishment is still gained from breast milk. Tough chewing. Natural single-ingredient foods usually require tough chewing in order to be ingested. Toddlers should be encouraged to chew their food properly until it is mush before swallowing. From about age 3, toddlers should be able to eat a wide variety of natural foods. Myofunctional therapy. The myofunctional exercises can start as early as age 3. This therapy can be done at any age throughout life, but it becomes increasingly more difficult to change posture and habits as the child gets older. Myofunctional appliance. These appliances can be worn from about age 4. A custom-made function-regulating appliance can be worn from about age 5. Facial growth assessment. An experienced practitioner will already be able to recognize developmental problems from a very early age 3 or 4. At age 6, these problems are much easier to diagnose. Early intervention. This therapy can start from about age 5, but the general recommendation is to start at age 6 when the first permanent molars have erupted. The appliances direct the natural growth potential of the maxilla and mandible. For this reason, the therapy can only be truly successful while there is a high level of naturally occurring growth. Many practitioners specializing in early intervention therapies will agree that age 8 is too late to begin an early intervention treatment. Good habits for life. There are certain good habits, physiological processes, and lifestyle choices that need to be part of everyday life for growing children and adults. These include permanent nasal breathing, correct swallowing, correct mandible position, correct tongue posture, proper diet, adequate dental hygiene, and breathing fresh, clean air. Bad habits and poor choices. Unnatural modern lifestyle choices, poor habits, and processed foods should be avoided at all costs. The consequences of these poor choices are not immediately apparent but can be devastating in the long term. Discussion. Nothing new. None of the concepts that have been discussed are new ideas. Good posture of the tongue, lips, and neck, and the proper use of the masticatory muscles have been part of the human experience since the beginning of our species. There is overwhelming evidence that suggests that modern human beings are experiencing a hereditary functional decline, and we are not reaching our full genetic potential because we exist in an environment that requires far too little physical effort. We have taken to artificial foods and artificial methods of baby feeding for reasons of convenience. Many people have recognized the need to train their bodies in order to tone their muscles for strength, bone density, and overall health, but very few people have realized that their facial muscles are in desperate need of resistance exercise too. The appliances mentioned are not new either. The early intervention techniques have been known for more than 60 years, but until just recently, have not been widely adopted or promoted by the dental profession. Children with poor facial growth and crooked teeth have traditionally been forced into an after-the-fact treatment option. The causative factors of the pathology were not investigated, addressed, or improved. The masticatory system. The masticatory system is comprised of 5 components, namely teeth, bones, muscles, joints, and the tongue. The arrangement of the teeth depends quite heavily on the proper functioning and use of the other components of the system. Muscle use is key to bone growth, and bone growth is key to proper dental arch development. All of the muscles of mastication, and particularly the tongue, play a vital role in the development of the masticatory system. If there is sufficient alveolar space and a good balance of forces, the teeth just simply cannot be crooked. Myofunctional therapy. Malocclusion is usually caused by an imbalance or absence of the beneficial forces. The appliance therapies mentioned can artificially apply these forces and achieve the necessary bone growth. After treatment, correct tongue posture and a healthy balance of the orofacial muscles is necessary to ensure long-term stability. Myofunction is essentially muscle function during eating and swallowing and posture during rest. It can be beneficial at any age and at any stage of life to revisit the goals of myofunctional therapy and check to see if one's orofacial muscles and resting postures are correct and in balance. In early childhood, the consequences of poor muscle habits are compromised growth and crooked teeth. In adulthood, the consequences of poor muscle habits are joint pains, snoring, and sleep apnea. Genetics and epigenetics. Our genes are constantly adapting to our environment. Any prolonged deviation from what is natural will have undesirable physiological results in the short term and also in subsequent generations. Growing to one's full potential starts from birth. The onus is very much on the parents and caregivers to play an active role to nurture and guide and also to lead by example. Form and function. There is a direct relationship between the morphology of the facial structures and the way they function. The techniques and behaviors discussed will almost surely help to develop the physiologic form and thereby improve the function and vice versa. Early treatment can drastically reduce unnecessary suffering. Children who use their masticatory muscles and have a normal tongue posture and a healthy balance of all of the oral forces will grow to their full potential and live their entire lives with efficient breathing, restful and revitalizing sleep, mental alertness, great facial aesthetics, perfect occlusal function, well-aligned teeth, and great self-esteem. Traditional fixed orthodontics. Malocclusion is most often caused by poor facial growth. Traditional fixed orthodontics is the most effective way to move teeth through bone in the shortest amount of time and exists as one of many last resort treatment options for teenagers and adults who were unable to achieve sufficient bone growth. Patients who elect to undertake such treatment should do so with full knowledge of the risks involved. Binding the teeth together in the preteen and early teen years, ostensibly as a remedy for crooked teeth, prevents outward growth of the maxilla and accelerates downward growth, which is the antithesis of what is actually required and only aggravates the poor growth pattern. An adult, all-permanent teeth, orthodontic treatment often involves extracting healthy teeth. This causes a loss of total tooth and bone volume. This loss of facial volume accentuates the deficient facial features. Mandibular growth. Mandibular growth and development rely quite heavily on maxillary growth, which relies quite heavily on the forces from the tongue and forces transmitted through the teeth during tough chewing. Improper occlusal relationships and insufficient occlusal contact between upper and lower molars can restrict the growth of the mandible. Compensatory mechanisms. Parafunctional habits such as tongue thrusting, bruxism and clenching are unconscious compensatory mechanisms which attempt to alter the physical structures of the unbalanced masticatory system. If these habits continue for prolonged periods of time, they can cause destruction and growth deformation. Habits, patterns, and postures. By using practical interventions, good habits and postures can easily be adopted and bad habits can easily be eliminated. Lifelong postures can be adopted at any age. A functional masticatory system depends on a balance of all of the oral forces. These forces are only effective when they are unconsciously and automatically applied. Timing is everything. There are certain growth milestones and unconscious behaviors that need to be accomplished at certain ages, and if help is needed, such help should be administered at the correct age. An orthopedic expansion appliance from age 6 can drastically improve the growth trajectory of the maxilla and mandible. Proper orofacial postures need to be adopted as early as possible. If normal healthy postures are disrupted, such as mouth breathing due to allergies and stuffy noses, parents should be able to recognize this and act promptly so that as little time as possible is spent in a state of imbalance. Problems and obstacles to implementation and patient education. Who, why, and when? After reading this book, many people will be wondering, why didn't we know about this? And why were we told to wait until age 11 or 12 before seeking treatment? And whose responsibility is it to inform the public about this avoidable pathology? There are many disciplines of healthcare with overlapping areas of treatment, but there is currently no particular specialty dedicated to early detection and treatment of poor facial development. Many practitioners are reluctant to incorporate early intervention treatments in their practice for various reasons. The general medical practitioner and pediatrician are probably not concerned with facial growth and dental health because they would assume those issues to be in the domain of the dentist and orthodontist. Understandably, most general dentists are hesitant to get involved with interceptive orthodontics because early intervention treatments are time-consuming, not highly profitable, and a specific aesthetic outcome is not guaranteed. The treatment duration is a number of years. Children with a growth deficiency would have to be monitored from age 6 to age 12. Removable appliances are, of course, only effective when worn. Patient compliance is a major factor and a source of frustration for the practitioner. Most orthodontists do provide a range of different treatment modalities for any age patient, but a large majority of their patients are remedial cases over age 11. Orthodontists usually term early intervention treatment as Phase 1 orthodontic treatment. Phase 2 would involve traditional fixed orthodontics to perfectly straighten the teeth. For many people, the cost of specialist treatment may be exclusionary. Most parents will unfortunately seek orthodontic treatment for their children too late, when most of the permanent teeth have already erupted. Fortunately, the early warning signs are unmistakable and can easily be detected by any oral health care professional and even well-informed parents. Ideally, all children should receive screening for dental health and orofacial growth progress at age 6, as part of school health programs. The purpose of this would be early detection to make parents aware of the current conditions and any need for preventative and therapeutic treatment. Inattentive and ignorant parents and caregivers. Ideally, parents, teachers, and caregivers should spring into action at the first sign of any bad habits such as mouth breathing or any parafunctional habits such as thumb sucking or tongue thrusting, etc. It is extremely unfortunate that most parents are completely unaware of the consequences of these habits. Parents need to observe their children during sleep and check for mouth breathing and snoring. It is highly irregular for a child to be snoring, and this can be a sure sign of an airway issue. Poor food choices. Almost all people living in modern society are victims of mass marketing and the prevailing cultural norms. We make decisions motivated by cost, convenience, familiarity, and enjoyment. Most people believe that every morsel of food they eat needs to be a dopamine-inducing delight. Artificial food manufacturers have engineered products that have a very palatable ratio of sugar, fat, and salt. People quickly become addicted to these products even though they have almost zero nutritional value and don't have a texture that resembles natural food. Natural single-ingredient foods that require great effort to bite and chew provide the daily resistance exercise needed to grow and develop the masticatory muscles and bones of the jaws. Children raised on purees, porridges, and other mashed and mushed foods are unlikely to develop to their full potential. Misdiagnosis. Many children suffering with sleep apnea are incorrectly diagnosed as having a mental disorder. Attention deficit and hyperactivity are normal symptoms of children who are not getting quality sleep. These unfortunate children are often given stimulant medication to keep them more alert in the daytime. Avoidable surgeries, necessary and cosmetic. Besides orthodontic treatment, many adults who have lived their entire lives with poor facial development are electing to have invasive surgery to widen the maxilla and the airways. Some people even have silicone chin and cheek implants placed on the chin, mandible and zygomatic arches to improve the physical appearance of their underdeveloped faces. Unnecessarily medicated. Millions of people all around the world are prescribed pain medications for the management of pain associated with temporomandibular joint disorder, TMD, or wisdom tooth removal. Unfortunately, many of these people become addicted to these medications. Time allocation. Busy mothers pursuing careers and other interests are increasingly finding it difficult to allocate sufficient time for nursing their children. Mothers are turning to commercially available artificial substitutes such as bottles and baby formula, etc. These products may be perfectly safe in the short term but can have severe long-term effects if overused during infancy. It is unfortunate that mothers are taking dietary and parenting advice from product manufacturers. Safe to use does not equate to good to use. There is unfortunately no adequate substitute for breastfeeding. A natural infancy requires the mother's constant availability for at least 2 years. The good news. Treatment offerings that are best for the patient. Due to the current widespread sharing of knowledge, there is an ongoing shift in public understanding and an increasing awareness that crooked teeth can be prevented if poorly developing children can begin treatment before age 7. Parents of young children are increasingly requesting early treatment for their children, and as a result more and more general dentists are beginning to offer early intervention treatments.